So let's go ahead. It's a little afternoon. It's probably time to go ahead and get started. I'm just curious, who doesn't know Dr. Beal? Everybody, you don't know, this is Dr. Beal? Really, everybody knows Dr. Beal? And so you all know how wonderful she is. Yes? Yes. I've never, my interactions with him over the last several years have all been wonderful. She's a great teacher, is doing wonderful things in the clinics and with the students and residents. She's a product of Shreveport, showing that you don't have to go outside the Shreveport to actually be this wonderful. And so with that, I'm going to get out of our way.
Thank you. Okay, so I debated talking about the flu vaccine, but then I thought I might die of boredom if I had to read about all of that and then talk about it for an hour. So go get your flu shots and tell everybody to do it. That's all I'm going to say about that. So we're going to talk about primary care for adolescents. And I've noticed here and there in the clinic, and I've heard some of our attendings say that in the clinic, some of these young adults that are transitioning into internal medicine, we're kind of lost sometimes because not everybody picks, a lot of us pick internal medicine because we like to solve a puzzle and we like really complex things, and we want a symptom to kind of work up and dig into, and that's not what you're always going to get with these young, well adults. So sometimes I think having a little training about it sets you up for feeling more comfortable in those situations. So if you don't care about this in any other way, shape, or form, at least if you get some questions right out of it, that would make me happy. These questions do show up on the medicine and training exam and the ABIM, and they're not going to be the portion of questions that are cardiology or other subspecialties, but why not get some other questions right and pass all your tests and not be sad. Okay, so there are kind of four purposes that we're going to talk about in preventive care visits. Four categories. So screening, counseling to reduce risk, immunizations, and giving general health guidance. There are a bunch of smart people at all these fancy organizations there to help us out with guidelines, and some of them agree pretty well and some of them are a little bit different, but they're all kind of similar gists. Some of them are just kind of based on expert opinion, or if we have some proven screening procedures and interventions, then we're able to have good data about that, but there's not there are not necessarily a lot of studies specific to adolescents, so we're kind of going with our best guess. Some things that were kind of universal that everybody agrees on. We want to prevent injuries and violence from accidents. We want to reduce the risk for future cardiovascular disease, so that may be somewhere that a lot of us feel more comfortable gravitating in our counseling. We want to reduce involvement in health risk behaviors and promote dental health, which may not be on much of what you talk to your patients about, but even just a sign in the waiting room that says, hey, did you know that dental health is tied to lots of other things? At least put it out there so people know to get their teeth worked on. There's less agreement between different organizations for teaching self-breast exams, self-testicular exams, providing this guidance to parents, which a lot of us go into internal medicine because parents are not our favorite, as a middleman between things. Whether to offer routine hearing and vision screening, whether to do routine hematocrits and urinalysis, and then how often should these visits happen. If you're a well 18-year-old, do you need to go to the doctor every year, or can it wait a couple of years? For simplicity's sake and for people to remember when that happened, I would just say every year, because a year starts to feel like 2 or 3 as you get older anyway. So an annual visit seems the easiest to agree on. So adolescence is supposed to be roughly from when puberty starts into adulthood. So that's a wide range of development. Even from the internal medicine part, the person you see at 18 is different from the person you see in their mid-20s. So there's a little bit still of kind of tailoring what you're doing to the developmental age of the person. And then you add on things like chronic diseases, and that changes people's developmental age too. So you are adjusting things to that. Okay, so think about what adolescents are trying to do. They're trying to separate from their family, develop a healthy self-image. They've got goals that they're trying to reach educationally. They're trying to be independent in various ways. And all of this keep their mental health intact, which has become ever more challenging, I think mostly due to cell phones. And then their brain, now, we've heard this brain development is not done until you're in your mid-20s, and now that's supposedly getting even worse because, again, of all the screen time, so people are not out doing all the stuff that their brain needs to do to develop until sometimes their late 20s. Okay, and then think about your own comfort and why some of these visits might throw you off. We go to medical school and we learn about diseases and disorders and how to manage those, and you look at a number and you try to reduce that number, or you look at an EKG and you have things that you can do to manage it. We don't necessarily get all this training on how to have conversations about preventable disorders, especially some that are a little more sensitive topics. So I get a lot of times the residents come to check out to me in clinic and say, I don't know why this person is here. Because they're a person and they're trying to make sure that they're doing what they're supposed to do and they're going to the doctor, so you're preventing stuff. We don't know how to write that note as well as number 1, diabetes, number 2, hypertension, number 3, COPD. We know how to write that all day long. Okay, ways that patients appear in our clinic. If they're graduating from a pediatric model of care, sometimes that's a smoother transition, and sometimes they just appear either because they've gone through the emergency room or something happened, they got in a wreck, and then the ER refers them to us for primary care management. So people kind of appear in different ways. The ideal way would be for them to get transitioned into an adult model of care, so that you kind of have a health summary of what's going on with them, especially if they have chronic conditions, and you have a better idea of a plan going forward. On top of all just the primary care stuff that we're going to talk about, if you throw on any child onset chronic illness, that adds a whole other layer, and some of these patients can be very complicated and hard to take care of and very time consuming. So the more things you have in place to get just their regular screening done, the easier it makes your life in taking care of the other things. This was just a study that looked at internist perspective and what were their kind of main obstacles. And I'm not going to spend too much time on this because I want to get to other stuff. The medical competency is not to say that we're incompetent. It's just, do we feel like we get adequate training in this? Is this the only time you're ever going to hear about adolescent stuff? Probably not. But if you don't feel like you get good training and good hands-on experience and someone that's motivated to teach you this stuff, and there's people out there too, then your comfort zone your comfort level when you see these patients is just not going to be there. Just FYI, if you are seeing some patients with chronic illnesses, there is a toolkit on the ACP website, and it has a different worksheet for different illnesses. So there's one for type 1 diabetes, there's one for sickle cell, there's all different ones, and they can kind of help these patients go to their pediatric provider, subspecialists, and get kind of a summary of what all they've had, surgery-wise, procedure-wise, hospitalizations, all of that stuff, and then that can kind of get things on the rolling a little better for you. Okay, so first of those 4 things we're going to talk about screening, and we'll just jump right into fun stuff. You're seeing a 19-year-old male prostitute for a first visit. You recommend that he be tested for STIs whenever he is symptomatic and at least every what? Dr. Suleimana says 3 months. Anybody agree? You should always agree with her. It's really very good. It's a good idea. So he's got a risk factor there that makes you say you want it to be more often, and every 3 months is the recommendation. So screen men for sexually transmitted infections. If they don't have HIV, men who have sex with men who don't have HIV, yearly or more for rectal chlamydia and gonorrhea if exposed, and genital chlamydia. So the rectal and pharyngeal swabs are those little white swabs, and they come in a kit with 2 of them. One's meant to be the urethral one. We don't do that one anymore. And then there's another swab in there, so I just get 2 kits, and I use that other swab for the throat and one for the rectal swab. And you have to just label the specimen from which site it came, so that the lab doesn't throw one of them away, which they did that to me one time because they thought it was a duplicate, and I was so sad. Then yearly or more for the pharyngeal gonorrhea for those who have receptive oral sex, syphilis and HIV at least annually, and then hepatitis at least once. And then men who have sex with men who have HIV at least annually for genital gonorrhea and chlamydia, and the rectal and pharyngeal testing if they're exposed at least yearly, syphilis at least annually, hep C at least annually, and the hep A and B at their first visit. Okay, the patient tests positive for gonorrhea. You recommend testing and treating all of his sexual partners over the past. How long should we try to find all the people? Let me guess this. So this one is 60 days. If they haven't, so look, he got it right. If there were no partners for the past 60 days, then you want the most recent one before that. So if it was 90 days ago, they got to go find that person. You can do expedited partner therapy, so that means that I know that you have this infection, and I want your partners treated, so I can give those prescriptions. And it is legally permitted in Louisiana. There's a little map online if you want to look at which states, if you move somewhere else, if that's allowed or not. And then you want to give them dual therapy. Okay, so for chlamydia, one of the risk factors for that is multiple partners. Pregnancy is another time that we screen for that. And then you're doing a test of reinfection, not a test of cure, at 3 weeks and 3 months. So it's not to see if your antibiotics worked, it's to see if they went and got infected all over again. Men who have sex with women, if they don't have HIV, obviously you would want to test them for that at least once in their life. And if they do have HIV, then genital gonorrhea, chlamydia screening at least annually, and syphilis at least annually, and hep B and C at their first visit. For transgender patients, you need to take into account the patient's anatomy. So if it's a trans male that still has a cervix, then you want to provide cervical cancer screening and then STI screening to look for bacterial infections like cervicitis. So you have to kind of, that's one of the times that it's really important to get a good detailed history. It's always important to do that. Okay, and then for women, if they're under 25 and they don't have HIV, annual gonorrhea and chlamydia testing, and then HIV at least once, and then if they have HIV, you could see that. You also want to offer screening for physical, sexual, and emotional abuse, and for learning or school problems. And then we'll do another question. A 20-year-old man is evaluated during a routine exam. He is asymptomatic. He's a non-smoker and has no history of illicit drug use, 2 lifetime female sexual partners, and sexually active in a monogamous relationship with a woman for the past 6 months. His father is 58 and has hypertension. His mother is 57 and has hyperlipidemia. His physical exam is normal. He had a fasting lipid profile 2 years ago, which was normal. And which of the following is the most appropriate screening test to obtain? Tina says C, and she signed it to me, so that's good. Okay, so if you're just on good test-taking skills in general, you know which section we're in, so HIV. So everybody 13 to 75 should be tested for HIV at least once, unless they specifically opt out. So you don't get consent, but it always is good to let people know that you're ordering this test and make sure that they're okay with it. Because if it comes back positive and you never had the discussion that it was coming, then it's just real awkward. It's awkward. And if they see it on their orders and you didn't tell them about it, they're going to go, why is she doing that? I don't understand. And then cervical cancer screening starting at age 21. Okay, so one thing that is always makes me happy that I did med peds is that I'm a lot more comfortable with these teenagers that have metabolic syndrome. So the screening for some of these things, obviously it's easy to screen for obesity, but we want to intervene here. So the whole point is that if you're not overweight or obese adolescent, you're likely to be an overweight, obese adult. So we want to hopefully prevent things. For cholesterol screening, this is kind of one of those controversial ones, depending on who you look at. For the peds visit at between 9 and 11, you're supposed to check a cholesterol panel. And then you avoid that during puberty because everything's all wonky during puberty. And then they want you to do one more screening between 17 and 21. So if the first time they popped up at the doctor's office is when they're 21 and they haven't been since they got their vaccines at 16, then you would want to order a lipid panel. This is when I think the medicine part and the peds part don't really talk to each other, because if I was just thinking with my medicine brain and a healthy 21-year-old who was not obese came in, I wouldn't order a lipid panel on them. But there you are. Hypertension, this also is there's disagreement about this, but it's a non-invasive test that's readily available, and we already do it at every visit, so we're screening for hypertension on everybody all the time, which is probably smart. Diabetes screening, the main thing to look at here to me is to pick which test you're going to use and make sure if you do have an A1C and a serum glucose that they match, because you can't say, if they don't have symptoms and those two don't match, you can't say they have diabetes based on one measurement. Does that make sense? So if their A1C is 6.8 but their glucose is 100 and they don't have any symptoms, then you got to do it again. If they match or they have symptoms, then you're done. You can move on after one reading. Okay, and then TB is not for general screening, just for patients with certain risk factors. This was one thing that we don't do at all because I have not seen this ever before, but the AAP wants us to do a hearing screen between ages 18 and 21, and I started getting a little fussy about this because we do a hearing screen at birth and then we do all these at these well child visits, but then I started thinking about earbuds and everything else that we do to our ears and guns and all that, so one more screening, fine. We have the little thing in clinic, it's easy to do, and you can bill for it, so one more thing to add on to our list of stuff. Okay. Millie is a 19-year-old female who presents for a sports physical. She has no complaints, no past medical history, is up to date on her immunizations, and her immune systems is negative. What health concerns do you need to think about for this young woman? The students have heard part of this before anyway, so I think they... Oh, y'all are so smart. Okay, so this is a generally healthy group. They're not going to have a lot of new serious medical problems at this age. So most of their morbidity and mortality are preventable things. So you may think it's not, you didn't take internal medicine to talk about bike helmets and all that, but I figure if we took an oath to do no harm, we don't want people to crack their head while they're riding their motorcycle, so let's just talk about helmets. This is kind of just a graphic representation that we don't need to spend all our time talking about heart disease and other things with these patients. We need to spend most of our time talking to them about things that they're going to get themselves into trouble with. So this is kind of a perfect storm. These are people that have kind of aged out of their parents taking them to the doctor, and their frontal lobes are still not doing all that they're supposed to do, and they may not have access to their insurance coverage anymore, and then they're doing all these risky things. So it's kind of, they're adrift in this perfect storm of badness. So if they make it into the doctor, especially the guys, girls I think come to the doctor a lot more than these guys do. So if they are there for anything at all, you should use that opportunity to do as much as you can. Okay, so unintentional injuries account for almost half of all deaths during adolescence. So that's car wrecks, guns that they were just tinkering with and nobody realized that they were loaded, drownings, poisonings, and then if you've worked in our ER or been in there for more than about 30 seconds, you see the evidence of stuff. And then if you've been in the PICU or the MICU or the SICU, I guess, you are now terrified to let your child ride a four-wheeler or do anything that doesn't involve a 5-point restraint. This is just a table from the U.S. Preventive Services Task Force with all their grade A and B recommendations. So they're basically all the things that we're supposed to be doing, and that's just the first part of it. So the super green stuff is for everybody pretty much, and the other things are based on individual factors. So I'm not gonna, that's there. I think it's handy to have these in an app form or whatever, or a picture of it on your phone, however you want to have it, but I'm not gonna go through all that. Okay, shots. I could not make this, I tried to make this picture, my friend, and it just wasn't gonna happen. So I'm gonna kind of go through individually the main things that you should, as these young adults come in, what you should be thinking about that they should have had, and if they haven't, how you can get them up to date. Everybody gets their flu shot. The green is everybody gets it, and then the other ones are individual circumstances. Okay, so we typically see kids for an 11-year-old visit, and at that time they'll get a Tdap. Before that, they've been getting DTaP their whole time, so their whole lives, so they're getting a Tdap. Their first dose of the meningococcal vaccine that covers ACY, ACW and Y, and then their first dose of Gardasil. So if they disappear forever after that, you may end up updating their tetanus situation. If they weren't ever given any tetanus vaccines at all, you would give a dose of Tdap, and then at least 4 weeks later TD, and then forever after that they just get a TD unless they're pregnant, and then all bets are off. If they didn't get Tdap at or after that 11-year-old visit, so they got their other primary series, then you give a Tdap now and then TD every 10 years. And then if they got their Tdap at that 11-year-old visit, then TD every 10 years after that. Exceptions are wound prophylaxis and pregnancy, and then if you don't know and it's the middle of the night and you have somebody that comes in for a wound, then just giving them an extra Tdap is not going to cause any harm. So err on the side that you can give it. There's no minimum interval, so if they say, I don't know, I got a shot a couple of months ago, I don't know what it was, could have been a tetanus shot, could have been whatever, it's not going to hurt them to go in and give them one then, because there's not a set time that it's a no-no like some of the other vaccines. Okay, and then for Gardasil, for the HPV series, it's a 2 to 3 dose series. If they complete the series before they turn 15, it's only 2 shots, so that's enticing for, at least for me, not to have to take my kid back for a 3rd shot. If it's after that, up through the age of 26, it's a 3-dose series, and that's for, what you talking about?
They approved it up to 45.
Oh, yeah, but up to 45, not for everybody. That's true. You can give it up to 45, so I think of that for HIV patients and then people that are in the high risk for various reasons. I'll just say that. Thank you. I thought you were saying 4 or 5 doses, and I was like, what? I got you. Thank you, Nick. Okay, and then for the meningococcal vaccination, they'll get that either Menactra or Menveo at their 11 or 12-year-old visit, and then they need a 2nd dose after their 16th birthday up through age 21, especially if they're going to live in a dorm. If they have complement component deficiency or asplenia, then you're going to keep giving those every 5 years. And then they have a newer one for the B strain of meningococcus. There's 2 choices for that. It's Truminba and Bexsero, and that's a 2-dose series for both of them. You just have to pick, it has to be the same one for both doses. So if you started with one, the 2nd dose has to be with the same one. We'll talk a little bit about Prevnar and Pneumovax. Somewhere when I was a student was when they had the Prevnar 7, and then 2010 I think was when they did the Prevnar 13, so just added some other serotypes to the vaccine. So I didn't do as many lumbar punctures as Dr. Beal did in his training, thanks to this and him. All of these people need a Pneumovax. We're pretty good, I think, about vaccinating all the 65 and older people, but all the younger people that have, that are just smoking, alcoholism, liver disease, all of those other indications, I think we could do better with. Especially if you think 20-year-old smoker, that just sometimes doesn't ring a bell in our heads that they need a Pneumovax. So the 23-valent one is inactivated. It's 23 serotypes that represent the bulk of the strains that cause invasive disease. It doesn't really do much until you're at least 2 years old. So kids that have sickle cell or other chronic conditions, we wait until they are at least 2 to give that series. And then they need to keep getting it every 5 to 7 years. So you're going to have to that's one of the populations you would want to look at with when their last doses were and keep them on that cycle, keep them out of the hospital. These are some of the under 65 indications. So I gave a lecture on immunizations every other week for at least 2 years for a while. So this is burned, the little chart, I have a chart that was from the CDC website burned in my brain of this. If you don't have that burned in your brain, and I wouldn't recommend giving that lecture 24 times a year because it starts to get old after a while, then just look online every time you're unsure about it. It's easy to find this stuff, and there's apps for it too. Okay, we can get all tied up too about who gets a second dose of Pneumovax under the age of 65, and I'm not going to get too deep into that because that's a whole other thing, but if you're uncertain, look it up. Then Prevnar 13 is the one we give to babies, so that was the one that's added more recently to give to 65 and older. And then adults that are under 65 need it for certain other conditions. If you see a patient and they've not had either vaccine for pneumococcal disease, then you start with Prevnar 13 and then go to Pneumovax after that. Okay, so on to counseling to reduce risk. And so you may remember the HEADS exam. For those of you that haven't done your pediatric clerkship, you're going to have to do one of these. It's the review system / social history for adolescents. So let's talk about that. It's an acronym, and they keep adding things onto it. So then it's HEADS, and then SHEDS, and then SHEDS. I can't keep up with all that. So we're going to talk about the basic one, but it moves from kind of vanilla things that are easier to talk about to the less comfortable things to talk about if you go in order, which I don't always, but that depends. And I don't always cover everything. Depending on what I've identified as the main problem for the day, I may just spend the whole visit talking about that. So these are just some example questions, and I'm going to keep going. One thing to think about, and I think this is when you're thinking about developmental ways to approach patients, this is a group that really responds well to encouragement and motivation and support of what they're doing right, and kind of coaching them to do things better if they're having some issues, rather than what we're all tempted to do is just show them the picture of the nasty STI things that happen to people and expect them to respond to that, and that's not usually what they're going to respond to. So find something good to say, like the feedback sandwich that we do with the residents. You seem like you're coming to all your appointments. I really appreciate that you're doing that. You haven't done any of the stuff that we talked about to get rid of these cokes in your life, but on the other hand, you did start exercising, so try to add some motivational stuff in there. Okay, so starting with the home, where do you live? Tell me about your living situation. Who lives with you? this is a time to talk about screen time also. Education and employment, if they're still in college, if they're working, what are their plans, how are their grades, are they missing a lot of school, especially if they have chronic diseases. One of the E's is for eating disorders, so including obesity, not just anorexia and bulimia. So if you remember being a younger person, especially a teenager, you think that everything is about you, so you can't just lead into these questions of, are you worried about your body? Because they're immediately going to think, she thinks that I'm fat, or she thinks that I'm whatever. So you need to say, I ask all my patients these questions. Does your body or your weight or the shape of your body bother you at all? And if it does, tell me about that. Pay attention to weight loss greater than 10% of their previous weight for eating disorders. Recurring, if they always are telling you that they're on a diet even when they're not overweight, if they are in the less than 5th percentile for their BMI, and some of these other signs on physical exam. I realize that this is rare for us to see, but these are people that are high risk for getting very sick. So when it's there, you need to not miss it. So people with anorexia are restricting their energy intake regardless of how low their body weight is. And they either have an intense fear of gaining weight or becoming fat to the point that it's not healthy anymore. Patients with bulimia will describe recurrent episodes of binge eating. They may not have much of a low BMI, but this is more kind of talking to them about some of the screening questions that I'll talk about in a second. So there are a couple of screening tools for eating disorders. Some the patients can just do on their own, especially the ones that are longer. This one's a quick one that you could do. Do you make the Scialfa Screening tool? Do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? So that's a stone is 2 pounds, right? 1 pound. Do you believe yourself to be fat when others say you're too thin? Would you say that food dominates your life? Then there's the eating attitude test. This one is something that they would fill out on their own. It's 26 items, and I don't want to read all those out to somebody. Plus, if you have a patient with an eating disorder, I think they're going to be much more likely they're not going to have the conversation with you. If you've seen patients with anorexia before, sometimes getting the truth out can be very challenging. But both of those have a high sensitivity and specificity. Okay, so on to the A for peer-related activities. So what do you do with your friends? This is also a good time to have your ears up for things that sound like depression. So I used to do a bunch of stuff with my friends, but I don't do that anymore. I just stay home by myself. Ask about the nature and the quantity of their screen time. The more and more talks I go to about this for parents, the more paranoid I am about all these things that are out there that our kids can get into trouble with. And that young adults whose brains are not quite done gelling end up sending naked pictures of themselves to people and thinking that it's immediately gone and not realizing that it lives somewhere far, far away. So talk to them about that. We're also in a place with lots of trafficking, so the more people put out there about their location and things about themselves, the more you just worry about stalkers and trauma. Okay, drugs. Asking about people around them that are using drugs and then their personal use of any. And I give a list sometimes. Especially if you say, do you use any drugs or do you smoke? You see the little twinkle in patients' eyes sometimes where you can tell they mean yes, I smoke, and they're talking about weed, and so you have to clarify that. Ask them about energy drinks, if they're doing any other things like vaping, since that's become a hot topic. using any of their prescription medicines that their parents left laying around, and then tobacco and cigarettes, including e-cigarettes. Okay, this is the CRAFT questionnaire. This is the alcohol screening tool that you probably have all seen. I'm gonna keep going. This is where some of us get derailed when we have to do this whole sexual history thing. I think people would rather, some of us would rather do anything but have to have this talk with our patients. So getting comfortable with this helps you make your patients more comfortable. So these are questions I ask everybody. It helps me take better care of you if I know the answers. I know it may be embarrassing, but we would just have to be able to be honest about this so I can give you my best advice. So sometimes I'll just say, tell me about your love life. Depending on the age of the patient, sometimes younger teenagers, there's not much to say and they just kind of go, oh. But as you get older, chances are that they've had some sort of romantic involvement with somebody. I also ask about episodes that were forced or coerced, because patients may not identify that as, since it wasn't consensual, that they're sexually active, if that makes sense. And then usually I avoid, are you sexually active at all costs as a question, because some people think that means like today before this visit, or does that mean ever? What does that mean? So just get rid of that question altogether, because most people don't know what that means. Okay. I'm just going to briefly kind of remind you that women of childbearing age have special considerations. So when I see residents that want to start a woman on lisinopril and they haven't asked her about what she's using for birth control, if she could possibly get pregnant, we want to prevent bad things from happening. So you want to think about folate supplementation. For this age group, long-acting reversible contraception is your friend. So that's IUDs and implants, because they don't rely on a person with a brain who hasn't kind of continued or finished forming to remember something every day. Okay, suicide and depression, the way they word the depression screening is always weird to me, so you should do that if you have systems in place to ensure accurate diagnosis, psychotherapy, and follow-up. We have those systems in place here, so we should be screening for it here. I don't know why you wouldn't. Anyway, think about asking about irritability instead of just sadness, or boredom, sleep disturbances, eating disturbances, kind of a little bit different than asking the helpless and hopeless and sad kind of questions. This age group is also where some of those mental health disorders start to emerge, and there's a little peak in bipolar disorder or schizophrenia and some of those, so have your radar up for that. Suicide is one of the big things in this age group, and it's always, no matter how much time I have spent in the room, it bothers me if I don't get to ask these questions, because if someone goes home and kills themselves and I didn't at least talk about it, then it will forever haunt me. So I prioritize this one, and I'm pretty blunt about I think everybody is not trying to sugarcoat what I'm asking. Do you want to hurt or kill yourself? Do you want to die? Do you have a plan for that? Have you ever made a plan for that? And just being as direct as possible. Okay, actually the nurses I think do this PHQ too, so here's one thing off of your plate. You can at least review it and see if there was something that popped up here, and if nothing else, at least know that those two questions got asked. If the score is 3 or more, then there's a likelihood that there's some depression there, so you want to dig a little deeper. Okay, safety. So we already kind of talked about a little bit. This includes gun safety, car safety, texting while you're driving, all of the things that people can do to get themselves into trouble. Okay, in Anticipatory guidance. So if you went into internal medicine, this is probably a term that long fell off of your radar to put in your plan, your assessment and plan, but you can now say you discussed anticipatory guidance if you wanted to, so you have something fancy to write to say you did all this stuff. So recommending seatbelts and helmets, regular exercise, and I give them the goal of 150 minutes a week of aerobic activity, and if they seem like that's doable, then I add on the 90 minutes of strength training or resistance training. Sound dietary habits, whatever you're going to pick to talk about for that. This group needs good sleep, and that's 8 to 10 hours, closer to 10 hours, especially for the younger adolescents. Healthy sleep habits, so no screens in bed, calming bedtime routine, all of that stuff, and then responsible sexual behaviors. Avoid tobacco. Talk about alcohol, especially depending on what age you're talking about here. They're not even really legally supposed to be drinking yet. I know where we live, so I'm not naive about that. I also have, anyway, I'll go get to that. Anybody that knows my family knows they're typical Louisiana kind of thing. Abusable substances, anabolic steroids, avoid all those things. Talking about online behaviors that put them at risk for negative consequences, ways to deal with bullying, firearm safety in the home, sun protection, and then transitioning patients with chronic disease. All of this can easily just be in your patient instructions as one of those little ABS things that they take home. So if you can't cover it all, at least there's somewhere in there that says all the stuff, and you pick a few things to talk about. If you can, before the visit, their patients can go through the patient portal and fill out their medical history and their surgical history and all of their social history. So if they do that beforehand, that helps. So encouraging people to use the patient portal is really helpful. You can administer questionnaires in the waiting room, so that gives them some homework to do while they're waiting for you to get done with the person before them you're asking all these 50 million questions to. So you don't have to, it doesn't have to be an hour and a half going through all these things. You just get the information, and if there's something that pops up on it that is a concern, it looks like they're smoking, so let me spend more time talking about that because everything else looks fine. Then with your history and physical, you're gonna kind of target into whatever is you've identified as the more pressing problems. When you're making a plan with these patients, it's good to kind of, okay, let's get a solid plan that we think is doable, and that's lots of motivational interviewing and trying to kind of be a team of what you think from the patient's perspective are the most pressing problems, because you may have your priorities and they may have theirs, and you've got to kind of decide where you're going to meet in the middle on that. Try to listen to the patient's perspective. So even it's the same your parents probably did to you. They can tell that you really should study, but you really want to do this other thing, and so they just kind of let you figure it out for yourself if it's not going to kill you. And so if you can do that with these young adults, then that might help keep your sanity. Okay, and then these are some resources that if you wanted to find out more, and if you just want extra help, I'm always here to help with teenagers. Any questions? Dr. Walter?
One of the challenges that we see, like in the pulmonary clinic, is kids who have been chronically ill, whether it's bad enough asthma that they're seeing pulmonary or whatever other chronic disease, is sort of making that transition and having the mentally competent patient take ownership of their own health. And there's always sort of the parent-child interaction. So what's the magic bullet for actually getting them to do that?
Oh, that's another talk. I'm not going to talk about that. Just so as much as you can, there are, I know this is one of Dr. Suleiman's things too, is these adult people that their parents are still running the show, and sometimes they need a little bit of support still, but they don't need, you have to kick the parent out. Sometimes that in itself helps, because you have part of the visit with the parent in the room, and say, you know, what you're saying is valuable, but I need your child to be able to do this stuff when you're not around, and one day you won't be around. So I need you to go to the waiting room for like 10 seconds and let me talk to them and put some ownership on them. And so the people that are number-wise, they're adults, but they haven't quite caught up with their peers, that's a way to kind of help. It doesn't mean that it fixes everything, but putting it on them as much as possible. If they always can rely on their parents to pick up their prescriptions and always rely on them to do everything, they're never going to become independent.
And is it generally well received by the parents?
I have not ever had a problem with that. Especially some of the parents, especially, I mean, you're dealing with it from a different angle, but they want the physician to help them help their child navigate some of these adult things that their kids have stopped talking to them about. And they're like, okay, if you'll just at least talk to them about sex, then that would really help me out because they won't listen to me anymore. If you kind of come at it from a, you know, this is meant not to exclude you from the visit because I still want your input, but I have to help them prepare for the day when you are not there. And then they might cry because they're thinking about their own mortality and they miss their child and they love them so much, but they usually don't get fussy about that.
And then on the child side, how do you begin to get them? Granted, the suggestions you have, I see that as being part of that. Are there any other tricks in terms of getting the child to stop in the disease state as a pawn in the parent-child interaction? Because I mean, sometimes they're like, well, they'll stop taking their medicine, or they won't take it the right way because it gets mom mad, and then distracts her from whatever else. And there's sort of,
as much as you can, if you cannot ride the wave with them, if you can be just the, so what I'm seeing here is that you made a poor choice, and I kind of, it's probably the way I need to learn to talk to my kids, but I can't not ride the wave, I get mad. If you can objectively and not see, just, you know, mess it all up, take that part out of the equation and just say, you know, it's not going to all be 100% perfect. You fell off the wagon a little bit. Let's get back on, and if you can celebrate some little small thing with them, the dynamic of what goes on in their family, I don't think you can ever change. But if you can give them some little taste of like, okay, you did this thing right, then people respond really well to the positive sometimes. Sometimes you can't do anything and then it just deteriorates and you watch it all go down the
the type one.
So will you tell the residents and students how you engage adolescents? How do you get them to trust you and open up to you? Because sometimes they're very reluctant and sullen.
Yeah, it takes a lot of visits sometimes. Teenage boys, I get, like, there's some visits where the only thing I hear out of their mouths the whole time is yes ma'am and no ma'am, and then they won't say anything the rest of it. But after sometimes it takes a few visits where they'll open up a little bit. Once they, especially the ones under 18, once they see that I really mean it about confidentiality, then they're willing to open up a little bit. Once they're 18, it doesn't, I mean, I don't really give the parents the option to stay in the room for the whole visit, because if you do the whole, do you mind if your mom's in here for this, you're just going to miss out, because they don't want to say, most of them don't want to say, you gotta kick her out. So you just say, my expectation is that part of the visit you'll be in here because I want that information, and part is that you'll leave because there's just stuff that we have to talk about on our own. I sit down, I make a lot of eye contact, I don't get mad at them when they do stupid stuff. I try to, non-judgmental. I probably talk way too long, as most of the residents make fun of me for doing, but I think if you invest some of that time, especially at the first visit, then the ones after that get a lot quicker. You're not, you just get over some of those hurdles.
How do you get them off there?
I might be a little passive aggressive about the phone sometimes, if they answer a phone call or they're texting while I'm talking to them. But I usually try to say, as soon as we get done, you can have all the screen time you want in the world, but if we're going to get the most out of this time, you really have to put that away. So most people will abide by the little signs that say put your cell phone away. And or I'll say if that's a really urgent thing, and I can tell sometimes it really is their another doctor's office calling them, a subspecialist office calling them or something. If that's really urgent, then go ahead and get that. But if it's not, if it can wait another 20 minutes, I promise I'm going to get you out of here. Some of them are just so like clueless about it, and I'm make those visits quicker. Anything else?
You noticed any issues with compliance with the HPV vaccine, especially in boys?
Well, one of the things is where our rates for vaccinating boys is much lower. I don't find as much of a problem with people that are coming in for their well visits with getting that one as I do for the flu shot. Just for some reason, the flu vaccine is like, everybody's got this. There's just a lot of angst about that one. If I have a good, if I say I frame most of the vaccines as it's time for this shot. I'm going to go in and order those today. Let's talk about what it's preventing, and I go through that stuff instead of, especially for adults, because if you say, do you want to get your tetanus shot today or do you want to get your shingles shot today? The answer is always no. They don't. Of course they don't want it today. But you turned 50 and it's time for your shingles vaccine. I'm going to send that to your pharmacy, and it's a 2-dose series, and I want you to try to get it before you come back. And then I don't really give them much wiggle room. Sometimes they'll go in and say, I'm not going to do that. But the HPV one, they're at that 11-year-old visit, they're getting it with a tetanus shot and the meningococcal vaccine. So those kids all they know is that they're preventing cancer and other bad things. They don't I try not to get too tied up about their parents worrying about sex and all that stuff. And then usually if they're going to get that first one, they'll come back for the next one. And that might not be in 6 months when I wanted them to, but you can catch them up. You don't have to start the series over. You just do it when they come back. Mostly I think if people like their doctor and they feel like you care about them, then they will come back.